Hello everyone, welcome to my channel. First of all, thank you very much for your messages and comments, and sorry for the delay in uploading the next video. And before we start this lecture, I just want to emphasize a thing. Sometimes it is not possible to answer a question specifically of the prescription or drugs part based on a single sentence or scenario provided by you because there is no proper case history given. Because the interpretation can be different when you miss some crucial information from the case history. So I just don't want to give you a wrong answer because let's say, if you missed some information in the case history which was important, so your answer will change. So I don't want to give you the wrong answer. So I will please suggest you all to wait for the prescription questions regarding to that topic when we will cover the prescription part. Okay, so let's continue with this video. In today's lecture, we are going to discuss another template which is asking about diagnostic aids. What tests should be done to reach a diagnosis for a particular condition? Now again, reading the case history is very important. Pay attention to all the details including chief complaint, history of chief complaint, and sometimes there is some additional information given before the question. So you have to take that information into consideration as well. Okay, because sometimes you are provided that information for a specific tooth for which the diagnostic test is asked for. So look carefully whether they have specified any tooth, whether it is anterior or posterior. Why it is important? Because in interior, Bitewing is not generally taken, so it can be a benign option. So as you know, there are generally, if we divide broadly, there are generally three kind of options. So first is, which is the correct answer? You are sure about it and it will fetch you marks. Another is incorrect, which will lead to negative, which will lead to cancellation of your whole right answers. Next is benign, which you are not really very sure, which is not wrong, but which is not exactly right. This is tricky. So these might not give you the negative, but these might not fetch you any marks. So you never know about these options. And so it is better not to choose the benign options. Choose the options which you are very sure of that these are correct, and avoid the options which are incorrect, which you know these are not correct. So for any, moving further, so Bitewing for anterior is kind of a benign option, so we should not take it. Another is, we have to take care that, let's say in the case history, pay attention to the words. Let's say if it is given pain or sensitivity. Because when there is only sensitivity, when the whole history, everything you read, and it is pointing towards sensitivity only, then thermal test becomes more important than the EPT. So you have to take care of these things. You have to pay attention to these words. Then next is, try to figure out whether pain is from pulpal origin or it is gums related. It is periodontal problem. Because in periodontal problem, EPT or thermal test are not done, because these tests we are doing to check the vitality of the tooth for the pulpal condition. So here what becomes important is evaluation of occlusion. Assessment of tooth mobility, these become important. Another is, look for specific informations. Let's say if a tooth is specified, and let's say whether it is given the tooth is RCT treated or full metal crown is given, in that scenario you will not do EPT, no thermal test, because vitality test, those are vitality test. So in nutshell, these are the few things you have to keep in mind when you are going through the case history. Pay attention to all the details. It is very important for you to further answer your questions. So let us begin. So this template is asking, in addition to periodontal probing and palpation, remember one thing, they have already mentioned two things. Periodontal probing and palpation we have already done. Other than these two, which of the following is are indicated to establish a diagnosis for this patient? Here they can specify you a tooth number. Here they can ask you that you have to go back to the case history and you have to figure out that which tooth they are talking about. So let us have a look at the options. These are periapical radiograph, Bitewing radiographs, panoramic, tooth percussion, application of pressure of individual cusp, assessment of tooth mobility, EPT thermal test, evaluation of occlusion, selective local anesthesia, blood testing, microbial testing, cytological smear, incisional biopsy, excisional biopsy. So if you look at all these options, you can see that there are some options which are not generally done for a tooth. Periapical radiographs, Bitewing, panoramic, yes, you will do for a tooth, but incisional biopsy, excisional biopsy, blood testing, no. So we will discuss these things in detail as we move on. So let us continue. So first is periapical radiograph. Periapical radiographs are used to detect any kind of abnormality in the root structure and the surrounding bone structure. So when you have pain in periapical region, which is because of endodontical region, that is there is a dental pain, you will take this radiograph. And to see the periapical region as well, and so first basically we have to look for the tooth number, any kind of anterior and any anterior posterior region. You can take periapical radiograph. Okay, we can take periapical radiograph whenever there is any kind of a dental pain and endodontic pain. So what do we see in the periapical region? Let's say any kind of infection, periodontal health, to assess roots before extraction, any pathology like cyst, implant position assessment post-operatively. When we do not take this, in the cases of trismus, it is contraindication. Obviously, we cannot take it if in the case history it is given that patient is suffering from trismus, you will avoid taking this periapical radiographs. We will not take this. Or any kind of gingival diseases, mucosal or gingival diseases, we will not take periapical radiograph. So this is really important. Periapical radiographs is kind of a very good choice when it comes to any kind of dental pain. You can always choose this option when it is dental pain. Moving on, it is Bitewing. For Bitewing, first of all, see which tooth is being asked, because as we have discussed in previously that if it is anterior tooth, we will not choose this option. If it is posterior, we will choose this option. And it can be used in dental pain, endodontic region pain, which is going to periapical region, and in perio cases as well. It is done in cases of whenever there are recurrent caries and we have to check the existing restoration, we do Bitewings. In detection of interproximal caries, Bitewing is really very important. So these are the cases which we have mentioned here, that periodontal bone loss, we will do vertical Bitewing. Recurrent caries, we can take Bitewing, we will choose this option. And if we would want to assess an existing restoration, we will. Not taken in, again the contraindication is trismus. It is not taken in trismus, and of course it is avoided in the anterior teeth. Moving on to next is panoramic radiograph. In case of panoramic radiograph, we use it basically for assessment of growth of children and adolescents to view in the mixed dentation period. So whenever there is mixed dentation and we have to evaluate the third molar condition, like let's say growth screening, we use this option in growth screening. Then in edentulous patients, we use panoramic. Then whenever there is trismus, we take this panoramic. Whenever the area is difficult to access, we take this. For growth screening cases, this is taken to find any kind of bony abnormalities. For TMJ viewing, it is done. And for impacted and third molar region, it is done as well. So panoramic is a choice in all these conditions. Specifically, when there is trismus, we will not choose the periapical, and we will use this panoramic radiograph. Moving on to next, these are actually, we don't have much to study in these, panoramic, periapical, Bitewing. We just have to know a few things which we have listed, and this is like, there is nothing much to read in these scenarios. Moving on. Tooth percussion. Tooth percussion is used to ascertain an inflammatory condition in the apical periodontium of the tooth. So it shows the inflammation in periodontal ligament, not the vitality of tooth. Just remember this thing, it does not tell us about the vitality of the tooth, but it tells us about the inflammation in the PDL. Example, acute periodicular periodontitis. So when the tooth which has symptomatic apical periodontitis, it will be more sensitive to percussion than the contralateral or the neighboring tooth. So when we do percussion on the tooth other than the tooth which is affected, the response on the tooth which is having periodontitis will be more. Endodontically involved teeth will respond more to the, we know there are two types of tooth percussion, vertical and horizontal. And the teeth which are endodontically involved, they respond more to the vertical percussion, and which are having periodontal lesions, as not lesion, periodontal diseases as abscess, they respond more to the horizontal percussion. So this option can be chosen for both the periodontal and the tooth pain, because it is not generally specified which kind of percussion are you doing. So it can be done on anterior as well as posterior tooth. If we see the case history, it can be done on both the anterior or posterior. In tooth pain, you can do it asymptomatic apical periodontitis. In periodontal condition as abscess, horizontal percussion can be done. So we can always use this. So TUP positive means there is apical inflammation, that is periodontitis is present. TUP negative, if there is no tenderness on percussion, it means there is no periodontitis. And the periodontitis and everything, the conditions we have discussed in the previous video. So if you have not seen, please watch the other videos as well. Thank you. Next is application of pressure. Next is application of pressure on individual cusps. So it is used in the posterior teeth, and it hints at cuspal fracture. This test is very specific for the cuspal fracture. Whenever there is pain on biting, we can use this test. So whenever in the history it is given that patient has pain on biting, or there was a trauma to the tooth, we can always choose this option, application of pressure on individual cusp. And one common finding which is associated with fractured cusp or cracked tooth is that it might say in the case history that there is presence of pain upon release of biting pressure. So sometimes they used, which is an indication of fractured cusp or cracked tooth. So pay attention to all these details. So in case of parafunctional habits such as bruxism, etc., you also tend to use these tests as well, because they might, like, read the whole history, they might also indicate that there are some parafunctional habits such as bruxism is present, or patient has a habit of grinding his teeth, and and it is given that there is pain on biting present or there is trauma present. So you can always choose this option. So moving on to next, assessment of tooth mobility. There can be many reasons of the tooth mobility. It indicates that periodontal ligament attachment is compromised, PDL attachment is compromised. So assessment of tooth mobility is an option which can be used whenever you see in the case history which is indicating towards a dental problem or as well as a periodontal problem, whether the pain is tooth related or periodontium related, you can always use this option. And it can be done on any tooth, and this option is like comparatively safer option, which can be used on all these in both the dental as well as periodontal conditions. And as you know, we don't have to go into the details, but we know that there is a Miller's index, which is an index for tooth mobility. Like score is 0, then there is physiological tooth movement, that is normal, 1 mobility up to 1 mm. Score 2 is mobility of 1 to 2 mm, and score 3 is mobility over 2 mm, or rotation or movement in vertical direction. And the thing is that this Miller's index is not really important when it comes to ACJ, but just to have an idea about that. And if there is given that patient, in the case history, if it is mentioned that any acute or chronic physical trauma, occlusion, parafunctional habits, any kind of periodontal disease, root fracture, extension of pulpal disease, so any kind of those conditions, and you can use, that's why we say that it is safer to select this option. So this was all about assessment of tooth mobility. Moving on, next, EPT. Moving on to next is EPT. So electric pulp testing is a diagnostic aid which is used to which helps us in establishing the health of dental pulp. Okay, so basically it tells us whether the pulp is healthy or no. We know how to do it. We apply a conducting medium and on a dry tooth, and with the help of electric pulp tester, we confirm this test. So it basically tells us whether the tooth is healthy or not, whether the pulp is vital or not. So if EPT is positive, that means there is vitality. It eliminates pulpal necrosis. That means pulp is vital. It means tooth is vital. So this is the important part of this test. It is a vitality test. If EPT is negative, tooth is non-vital. Now, when you read a history, just pay attention to all the things they have mentioned, whether they have given only EPT, only cold test, or both. Sometimes the scenario are given as such that EPT is positive, so you will say the tooth is vital. EPT is negative, so the tooth is non-vital. Now sometimes with EPT, cold test result is also given. So EPT is positive, cold test is positive. If both the tests are positive, it means the tooth is vital. If EPT is positive, cold test is negative, then what will you say? Again, the tooth is vital, because it can mean that the calcified canals may be present because of which cold test was negative. But you have your EPT positive, and that is a diagnostic feature which tells you whether the pulp is healthy or not. So that is the tooth is vital. Now, if they have mentioned EPT negative and cold test negative, then tooth is non-vital. The thing is that don't assume scenarios. If no response to EPT, the tooth is non-vital. You don't have to assume the scenarios that maybe the patient, maybe it is a recently traumatized tooth, maybe the patient is under the effect of some sedatives, analgesics, that is why the patient is not responding to EPT. So you don't have to assume any kind of scenarios. If it is given, until and unless it is mentioned specifically, you don't have to assume. So if it is given EPT is negative, the tooth is non-vital. If only cold test is given and cold test is given negative and EPT is not mentioned, again you will say the tooth is non-vital, because then you will not assume. Here we were given that EPT is positive, cold test is negative, that is why we said tooth is vital. Not because we are assuming that cold test is negative, but EPT was positive, so that is the main indication here. I hope you got it. Moving on to next, it is done in adult patients with dental pain. It can be done on any tooth which has problem. Now, when do we not use EPT? Specifically in endo-treated tooth, post and core, because we know that we are doing this test to check the health of the pulp, and for endo and post of core, so we will not do these tests. Non-vital tooth. When in the case history it is already mentioned the tooth is non-vital, sometimes if it is mentioned the tooth is non-vital and you are asked to check the diagnostic test, it doesn't make sense to use this test again, because when they have already specified the tooth is non-vital, why will you do EPT? It can be benign, it can be wrong, we never know, but it is not a correct option, that we know for sure. Again, then in children, it is not advised to do so. Adults with pacemaker, it is not done. So again, the patient under the effect of sedatives, the patient has taken analgesics, if they have specifically mentioned this thing. So again, this is not contraindicated, but not very right answer. So it's up to you. If it might be benign, it might give you 0.1, so doesn't matter. So main thing is you have to take care if EPT is positive, tooth is vital. We have already discussed how to check whether the pulp is normal, whether irreversible pulpitis is there, whether reversible pulpitis is there on basis of EPT and cold test in the other videos. And if you have not seen those videos, please do that. Moving next, thermal test. Moving on to next is thermal test, cold or. So this is done in dental pain. It also aids in checking the vitality of the tooth and it helps in the endodiagnosis as well. So as we have discussed earlier that if cold test is positive, that means tooth is vital, and if cold test is negative, that means tooth is non-vital. So as we have discussed, do not assume scenarios as calcified canals may be present, take at the face value. And if both the scenarios are given EPT and cold test, that is a different scenario, and then answer accordingly. So what happens is we have discussed that if a response to a cold test, a thermal test is transient pain, and for few seconds only, and as you remove the stimulus it disappears, it is normal, it is healthy. Then we have no response to the thermal stimuli to the cold test, the pulp is necrotic. If there is lingering pain after the stimulus is removed, it is irreversible. And if for few seconds but the pain is sharp, it is reversible. Again, these we have discussed in the previous lectures. Please go through those as well to have a better understanding of this thing. So it is not done in non-vital tooth when there is a crown placed, when there is endo-treated tooth, post and core, and avoid in children. It's not contraindicated, but you don't do it. And again, if patients are under sedatives, it might give you false results. So it is up to you. It can be a benign option. Otherwise, like, it's advisable not to go for these options in those scenarios if it is specifically mentioned. Then moving on to the next topic, which is evaluation of occlusion. Evaluation of occlusion, again for dental pain, for periodontal problems as tooth mobility. Whenever in the history it is given that the tooth is mobile, tooth mobility is given, occlusion can be evaluated. Whenever there is occlusal interference, hyperocclusion is given, you can always opt for evaluation of occlusion. Any kind of parafunctional habit, bruxism, clenching of teeth, extrusion of teeth, given in the history, you can choose this option safely. Extrusion due to trauma, any traumatic condition given, you can choose this option safely. So evaluation of occlusion is a safe option to choose in the endodontic pain as well as periodontal problems whenever mobility is given and whenever you can see there is something to do with the occlusion as well. So you can choose this option. So moving on to the next topic, which is selective local anesthesia. Now, till now, all the other approaches we have discussed, all the other diagnostic tests which we have discussed till now are conservative, but this is quite an invasive technique. So it is done when all the exams mentioned are inconclusive and the pain is not localized. That is, we have a referred pain. Patient cannot specify whether the pain is from upper jaw or lower jaw or upper jaw, or from which area it is actually happening. So the patient complains of severe pain and we have done the EPT and all other tests and these are inconclusive. So what happens? We will anesthetize infiltration or intraligamentary, and it is done in a manner that it is, we will anesthetize the most posterior tooth in the area, moving measly one tooth at a time. Let's say we have infiltration, we have given an anesthesia to the most posterior tooth in the area, and if the pain is still there, we can rule out that that tooth is not the cause. So we will anesthetize the tooth mesial to it. So if we still can't figure out, then we'll go to the blocks IA and B, let's say for the lower. So if still we cannot find out that which is the source, so we will block maxilla or mandible one at a time. And so we can say if we given a maxillary block and the pain subsides, then we can see the problem is in the maxillary area. And if not, then we have to anesthetize mandible. So when the problem in maxilla, it will go when blocked. If not, we check with blocking the opposite jaw. And if we have anesthetized both the jaws, but pain still does not subside, so there is some neurologic condition involved with the pain. So the pain is because of some neuralgia. So this is how, so that is how we can see that so many injections and everything. So this is quite an invasive technique, so which is only done when the other tests are inconclusive. Moving on to next. So these is not selected very often because you do not get such scenarios. You might, but till now you did not. So moving on to the next option, blood testing. This does not apply to the diagnosis of dental pain. So it is done when oral manifestation of systemic diseases is present. In cases of systemic diseases such as, let's say, coagulopathy, we'll do this to measure INR for patients on anticoagulant or liver diseases, patients in hemophiliacs, immunocompromised patients. It is done in immunocompromised patients to rule out the AIDS in cases of severe immunocompromised patients as NAGNAP, in severe cases of NAGNAP or major aphthous ulcer, let's say. So those immunocompromised patients, and when we have to rule out AIDS, we will do this. So as we know, healthy CD4 count is 500 to 1200 cells per mm cube. HIV CD4 count, HIV positive is CD4 count below 500 cells per mm cube, and AIDS is when CD4 count is below 200 cells per mm cube. So we'll do when the patient is immunocompromised and you have to rule out AIDS, we'll do the blood testing. Whenever there is systemic disease, any coagulopathies are present, we will do this. So in normal dental, not normal, in dental pain, in general conditions in dental pain, we do not choose blood testing. Only systemic, if there is given in the history any systemic disease, any immunocompromised conditions and systemic disease, and then we choose this option. Now moving next is microbial testing. Now microbial testing is when its main indication is for the patients with aggressive periodontitis. Whenever you see in the case history, it is given patient had aggressive periodontitis, maybe general, maybe localized, we will choose this option. And generally in abscesses, we do not do microbial testing until and unless it is a resistant infection. And in those cases only it is done to confirm which antibiotic is to give to which microorganism is responsible. So basically just forget about it. Whenever there is an abscess, dental abscess is given, you do not choose this option as such until and unless it is a resistant infection. So most likely whenever in the history it is given aggressive periodontitis, you will choose this microbial testing option. So the next option is, we'll move on, cytological smear. So what is cytological smear? How do you do it? So a thin tissue or blood sample, we take a glass slide and it is spread on that and stained for cytological examination, and it is seen under a microscope. Now, in what cases we do cytological smear, that is important. First of all, the viral lesions such as herpes or varicella. Herpes or varicella, viral lesions, we do cytological smear. Then pemphigus, pemphigoid, and candidiasis, you can use the cytological smear. So viral lesions, pemphigus, pemphigoid, and candidiasis, cytological smear is used. Not in dental pain. If a patient is having a pain of endodontic origin or periodontal origin, but no systemic or no viral, no pemphigus, pemphigoid, candidiasis, you will not use cytological smear. So this is indicated for only these 4 conditions. Moving on, incisional biopsy. Incisional biopsy is generally done when the area which we have to investigate is larger in size, so that we cannot excise the whole area. So we do this incisional biopsy. So whenever we have red and pigmented lesions, red and white lesions which are more than 1 centimeter, then we do incisional biopsy. So what we do is we take biopsy and we send it to the lab and confirm and treat accordingly. Again, non-healing ulcerated areas. So non-healing ulcerated areas, we'll do incisional biopsy. Whenever you suspect cancer, whenever cancer is suspected, you will do incisional biopsy. So size matters in red and white lesions. If red and white lesions are more than 1 centimeter, incisional biopsy. Non-healing ulcerated lesions, incisional biopsy. And whenever malignancy is suspected, incisional biopsy. To excisional biopsy. Red and white lesions which are less than 1 centimeter in diameter, that is, the lesions are small, so we will do excisional biopsy. We'll excise the hole and send it to the lab. Benign lesions, we'll do excisional biopsy. Size in case of benign lesion does not matter. It can be, example, fibroma, torus, you will do excisional biopsy. Pigmented and fluid filled lesion, as nevus, melanoma, etc., you will excise the hole, excisional biopsy. Vascular lesions, hemangioma, etc., you will excise there. So this is basically all the diagnostic aids, everything about the diagnostic aids which we need to know about. On to next, we have just an example. It is like in the case history. So it's just a crux that in the case history it is given that the patient's chief complaint was there is acute pain on lower posterior tooth, which patient have some relief on drinking cold water. And in the history of chief complaint, it says that pain on tooth 4-6, sensitivity to hot and cold as well, and now the pain is spontaneous. Okay, now the pain is spontaneous, so it is irreversible pulvitis. So what are the diagnostic tests? Now we are not doing the diagnosis, we are selecting the options. What are the diagnostic tests we have to do? So see, for one thing, first of all, it is saying there is pain on tooth 4-6. They have specified it is a tooth 4-6 and there is pain. And it is relieved by drinking cold water. So when there is pain, so what we will do, we will check with periapical radiograph the condition of the periapical region. We'll do tooth percussion. We can do assessment of tooth mobility. And we will do EPT and thermal test to check the pulp vitality. So here in this case, we will not do selective local anesthesia because we know the tooth 4-6 is responsible. We will not do any kind of blood testing, microbial, cytological, incisional biopsy, excisional biopsy. We don't need to do this. And then there's nothing sort of the pain on biting is there, trauma is there, nothing that sort of given. So we will negate other options as well. So we will not choose application of pressure on individual curves for evaluation of occlusion because nothing about the occlusion is given here. So our responses will be periapical radiograph, tooth percussion, assessment of tooth mobility, EPT, and thermal test. So this is how you're gonna approach all the questions. So I hope it helps. Thank you so much. And please watch the other videos as well. And we will do the prescription very soon. Thank you.